Good afternoon, and welcome to the next in our series of HFPN Lunch and Learn webinars. Today's topic is destigmatizing the stigma of mental health conditions. We will explore this topic in hopes of learning better ways to address the reluctance and the inertia that patients have when faced with mental health challenges. We will also highlight the impact that social and cultural factors have which further exacerbate the equity gaps that we see across our community. And as always, this webinar is approved for Category 1 CME, as well as it meets the LARA requirement for implicit bias training. And so we are fortunate again to have a remarkable group of speakers today. They each offer unique perspectives, and together they'll provide a diverse view of this topic. We will have time for questions at the end, so please write your questions in the chat box during the session. So I'm going to go ahead and introduce our speakers all at once, and then we'll turn it over to our first speaker. Our first speaker today is Kimberly Kowalek, who is the Director of Clinical and Social Health Integration for Henry Ford Health. Kim has an extensive experience and expertise in systematically gaining access to community-based services to help our patients cope with social determinants and other barriers to healthcare as well as mental health care. Our second speaker today is Dr. Denise White Perkins, who is the Interim Chair of Family Medicine at Henry Ford Hospital and Henry Ford Medical Group. Denise is an educator and a researcher with a special interest in healthcare disparity. She also serves as the Director of Healthcare Equity Initiatives for Henry Ford Health. And our third speaker today is Dr. David Moore, who is the Director of Trauma and Acute Care Surgical Psychology Services, which is a very unique position. David is also an educator and a researcher who has special interest in mental health challenges faced by patients and families after undergoing serious traumatic events. So with that introduction, I'm going to turn it over to our first speaker, Kim Kowalek. Kim, you're up. Oh, Kim, I think you're muted.
Never gets old, does it? Let me just say hello, everyone, and thank you, Dr. Muma and the HFPN team for the privilege to be here today. Social and environmental influences are said to contribute towards 45 to 60% of variations in one's health status. With that said, I think it's important to make a quick distinction between SDOH risk factors, and SDOH social needs. The World Health Organization defines SDOH as the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping conditions of daily life, including economic policies and systems, developmental agendas, social norms, social policies, and political systems. These circumstances are shaped by the distribution of money, power, and resources at a global and national and even local levels. When we're talking about addressing social needs, we're talking about an individual level, so providing an individual a specific referral or resource to address their need. When we're talking about addressing social risk factors, we're more talking about utilizing an SDOH screening tool to identify what that risk or what that potential need could be. So for example, if we're talking about housing, if we're addressing it from a global SDOH perspective, we're really working and encouraging legislators to support a living wage. If we're talking about addressing the social risk and social need, then we're talking about utilizing a evidence-based tool and then providing a list of housing resources. When we're talking about social drivers of mental health, they are not dissimilar from those of physical health. Mental illnesses are complex with a multitude of causative factors. They can be comorbid with other mental and physical conditions. In addition, physical illnesses can affect mental well-being and produce mental illnesses. We see this in literature surrounding areas such as diabetes and depression. Furthermore, mental illnesses can be exacerbated by environmental and social conditions and changes. Examples of social drivers of mental health include adverse childhood experiences, education, employment, poverty, food insecurity, housing, including one's built environment, and certainly discrimination, including minority ethnic discrimination, gender discrimination, and discrimination against one's sexuality. Adverse childhood experiences can be defined as highly stressful, traumatic, and acute or ongoing traumatic events which affect the individual. This can be at a family, social, community, and/or personal level. It can include maltreatment or emotional, physical, and sexual abuse. It also includes social circumstances such as violence, substance misuse, poverty, and can be a chronic, long-term sustained condition. Literature actually indicates about 16% of adults have experienced 2 to 3 childhood experiences, and almost 10% have experienced 4 or more. The CDC indicates adverse childhood experiences can lead to social, emotional, and cognitive impairment, can contribute to maladaptive health behaviors, leading on to physical and mental health illnesses, and can lead into premature death as a result. Evidence further suggests that adverse childhood experiences can lead to short and long-term psychological and physical health consequences in both men and women alike. Boys and girls, men and women, however, tend to respond to these experiences differently. Girls and women tend to respond internally with thoughts of suicide, low self-esteem, which can lead to behaviors such as self-harm and disordered eating, where boys and men tend to respond with more externalized behaviors that are frequently labeled as having problems behavioral problems as opposed to health problems. And this oftentimes leads to punitive responses as opposed to a psychiatric response. And this punitive response can be seen far more within Black persons and Black communities. Education is another social driver of mental health. And there is substantial evidence on the long-term impact education has on mental health outcomes. Education is known to equip an individual with skills to cope and manage with life stresses, and in turn, the capacity, therefore, to nurture others. Research by Cohen and colleagues demonstrate how educational attainment at age 25 can predict depression at age 40. Conversely, college graduates were 17 to 37% less likely to develop depression by age 40 when compared to those with a high school diploma or less. Employment, another social driver of mental health. Our work environment contributes to a sense of purpose and belonging and peer support. The longer the period of unemployment, the higher the rates of suicide are. Unemployment across genders, ages, and ethnic groups can have a differential impact on individuals and their families. There have been numerous studies that have found unemployment has a far greater impact on the mental health of men in comparison to women. Research has also demonstrated that men are far less likely to report possible symptoms of mood disorders, perhaps because such symptoms are inconsistent with dominant notions of masculinity. This is often perceived by healthcare professionals as a lack of engagement in health services and often can be labeled as stubbornness, when it is actually a part of a much more complex system and cultural climate. Healthcare providers are often influenced by gender norms and unconscious gender biases when treating a man or a woman. Another social driver of mental health is poverty. Poverty can be absolute or relative. Comparisons can be made across international, national, and regional parameters. Even within our own zip codes where we live, we can identify different levels of deprivation and poverty. Psychiatric disorders are far higher in individuals living in poverty, and likewise, those with mental illness may have a greater tendency to slip into poverty. Geographically concentrated poverty in places can be particularly detrimental in the health of children. Food insecurity, another social driver of mental health, is associated with significantly higher risks of anxiety and depression when compared to those with no food insecurity. In parallel, water insecurity was exposed when 100,000 families who were disconnected from water and sanitation services right here in Detroit, after falling behind on payments following increases in cost, and displayed significant increases in psychological distress during that time and thereafter. Outside of the unaffordable nature of food, access and availability also certainly play a role. Or it may be a lack of food altogether. A lack of fresh foods, vegetables, and fruits, which are often expensive, lead families and individuals to rely on far less expensive, high calorie, low nutritional foods, such as fast food. Malnutrition, especially in young children and adolescents whose brain are still developing, can lead to mental health consequences such as anxiety, sense of powerlessness, hopelessness, and depression. When addressing a food insecurity need, there is often a stigma by both individuals and healthcare providers surrounding food pantries. One having to stand in long waiting lines to get their food, the lack of dignity and not having a choice in being able to choose which food items they would prefer, and pantries not having specialized foods to support cultural or religious needs. Housing is another social driver of mental health. Inadequate, poor quality, and insecure housing adversely impacts the mental health and well-being of families, communities, and individuals. Related worries around health and safety can lead to anxiety, hopelessness, helplessness, feelings of being trapped, and depression for some. It may furthermore contribute to domestic violence, substance abuse, and inadequate schooling for children. Homelessness also has higher rates of psychiatric disorders. Just going to take a moment and share a personal experience, a very recent personal experience with housing insecurity that demonstrates healthcare provider stigma. My younger sister has some financial strains in her life, which therefore leads to challenges with finding affordable housing. She and her fiance and her magnificent toddler were offered the opportunity to move in with someone who was considered to be a family friend, so they could share rent. And they were offered 3 bedrooms in the back of the house, 15 minutes from me, only 20 minutes from my parents. My sister was absolutely thrilled. And then rent, of course, was far more affordable because they were sharing. My sister and her fiance were paying rent to this family friend who clearly was not using that money to actually pay rent, as they were provided an eviction notice and needed to move out in a very short period of time. Thankfully, my brother was off work at that time and was able to go help them move out. And again, we're fortunate enough that they were able to move in immediately with my parents. I'm one of 7, so there's plenty of space in that house now for them to live there. But just recently, my nephew had some upper respiratory concerns, and they thought that he was having an earache. So they went to the pediatrician to have him looked over. And thankfully, he was provided some antibiotics, which is fantastic. But they also subsequently wanted to screen her for her SGOH needs. So she shared that they were having a housing concern, but they were living with the parents. And she said that the healthcare provider immediately was frowning at her and was making very judgmental statements about what was she going to do with her toddler, was she leaving the toddler with my elder parents to take care of him, and so forth. Subsequently, my sister got a phone call from CPS, who wanted to come out and do a home visit because they were concerned that they were living in an unsafe situation and that their child might be in danger. Devastating to my sister. My 4 younger siblings are adopted and have a certain particular personal experience and feelings with engaging with CPS. So, she's therefore lost trust in community in terms of who in the community can she trust, but also lost trust with the healthcare system as well, being that she thought that if she shared that information with her provider, that the provider might be able to help her find a solution. And this brings me to discrimination. This is another significant social driver of mental health. This can include race, gender, religious affiliation, sexual orientation, and even skin color. The person experiencing discrimination is likely to feel inferior, may feel trapped, and develop low self-esteem, and experience long-term chronic stress, which increases vulnerability to mental and physical conditions. Brown youth with mental health disorders are more likely to end up in the juvenile system rather than receiving specialty care. And yet, when brown and Black youth are actively engaged in care, Black children are far less likely to receive guideline-driven care, and brown children are more frequently left completely untreated. And we see similar comparisons in maternal health as well. We know that explicit and implicit biases fueled by structural racism are playing a role in these differences, impacting social drivers of mental health. But I will leave you saying that there is hope. There are important considerations and actions that we can all take to address social drivers of mental health. And the first is being here today. So thank you for showing up, being engaged, wanting to learn. But to ensure that efforts are addressing social drivers of mental health to reduce racial, ethnic, and gender health disparities, we do need to maintain our commitment to our equity lens. And as I described in my personal story, trust is absolutely crucial. Building trusting relationships between staff and internal teams, service providers, as well as with individuals and communities that we are serving, all have a profound impact. Engaging in tools such as empathic inquiry training, it supports building trust by teaching how to engage in empathic, patient-centered, trauma-informed conversations, builds trust. We need to have more emphasis and priority on building collaborative relationships with non-clinical and non-health sector organizations, such as our area community business organizations, as we find individuals oftentimes have far higher levels of trust with community support systems. Further, we need to leverage multidisciplinary teams. Collaborating within and throughout all of our service lines makes us stronger and allows us to create a safety net around those we're serving. And then lastly, we need to acknowledge that social and racial disparities in healthcare are systemic issues, and we need to continue to advocate for structural level and policy level changes. Individual-based community interventions in and of themselves are impactful to that intervention, but they're not enough to move us further towards health equity. I know, though, that we as a Henry Ford Health team, we can make a difference as long as we stay together and we continually commit to making improvements. Thank you so much. I appreciate your time today.
Thank you, Kim. Thank you for your inspirational words, and also thank you for sharing that personal story. That was very, I think, elucidating to what you were trying to say. So thank you. All right, we're moving on to our next speaker, Denise, and I think Denise has some slides there, which are now on display. So Denise, the floor is yours.
Thank you. Well, good afternoon, everyone. I want to first just share my appreciation that you are taking time out of your day to be with us to discuss this very important topic, because this is a topic that's very near and dear to my heart as a family physician and also as a psychologist and researcher and educator. And I think that the more that we talk about it, the more we are positioned to move towards really having an impact in dismantling the stigma around mental illness and improving the quality of care and services that we are providing to our patients and to our community. As a family physician, I developed this topic thinking initially about how we can dismantle stigma around mental illness within primary care. But really, I am seeking to offer some thoughts that are applicable beyond primary care, because this is a call to action for everyone who is involved in the healthcare team. When we think about mental illness, we are thinking about mood, thinking, and behavior. And we recognize that almost a quarter of adults at some time in their life will experience some form of mental illness or dysfunction in that area. It's also costing our health system and our society a great deal. One of the statistics I looked at, it was over $105 billion in 2019 alone. And it's something that that cost is partially due to the fragmented nature of the way we provide medical care and mental health services, the fact that we don't distribute resources equally. And I think it's also partially due to the fact that we have not really dealt appropriately with the stigma that's underlying the way that we deliver care. So in my comments today, I want to offer some ways that we can challenge ourselves to think about mental illness within the broader context of our society, our health system, our community, and our role as providers. So in the next slide, I want to begin with just sharing a quote that I think can help us begin unpacking that. Often, as members of a healthcare team, we're focusing on diagnosis, putting someone in a box. But really, the concept of mental health in our society is really defined largely by the extent to which an individual is behaving the way our system needs them to behave and the extent to which they're not showing signs of stress or distress. Because if you think about it, we really often don't notice that someone has a mental illness until they start not functioning the way we need or expect them to. And so right there, that's the beginning of a setup for societal stigma. In the next slide, I want us to challenge us to continue to think about the way we identify and define mental health and mental illness. Again, our health system is built upon diagnostic codes, and we want to put people into boxes or according to particular requirements or parameters. But there are many who suggest that we need to think about mental health as being on a continuum. That can range from having a very positive outlook and feeling very healthy to now not being able to deal with stressors as much as well as we would like, to the next level of really suffering from severe mental illness, and there being a lot in between. As a practicing family physician, I find that it can be very difficult to bring up the topic of mental illness and mental health with our patients because there is so much stigma. And often it's the diagnoses and the medical jargon that we use to describe these conditions that end up creating a barrier for further discussion and treatment. And so at times I find it's helpful for me to step away from those labels and diagnoses to have more of a person-centered conversation with my patients, to use phrases like, how hard are you having to work to be okay? Rather than normal, abnormal. And I think opening up the conversation to help people think about it along a continuum can be very helpful, and it can be a way to open the door to needed diagnosis and treatment and services. In the next slide, I want to really emphasize the fact that there is no one simple answer to dismantling the sources of stigma. Kim gave a wonderful overview of how social determinants and social risk factors influence the way people experience mental distress or mental health or mental illness. And I think I just really would like to highlight that again, that stigma has a multifactorial source. It can come from the broader ways that our society is organized due to inadequate or unequal distribution of resources so that people can get what they need to live a healthy life and to have services for their mental illness. And it's also occurring within those broader societal discriminatory and inequities that we see. It also can show up in the way we interact with each other, prejudice that we might have or biases that we might have as we're interacting individually with people who have mental illness or mental health concerns. And then as a result of those structural and interpersonal stigmas, then we can also start to see people who are struggling with mental illness themselves have some stigma around their internalizing that and those messages of being less valued, less respected. So it really is a multi-level source to the stigma. And I firmly believe that if we're going to dismantle it, we need to be willing to look at things from all of those levels. On the next slide, I would like to now kind of challenge us to begin thinking about what we as healthcare providers can do and as healthcare teams to dismantle the stigma. This is critical because research has shown that people who have experienced mental illness commonly report feeling excluded from their healthcare decisions. They sometimes feel that there are subtle or overt threats of coercive treatment. At times, they may be made to wait a longer amount of time when they're seeking help or not given full information about their treatment options, not really truly engaged in that informed consent. Many may report being talked to in a paternalistic or demeaning manner, or being viewed as not ever going to get well or live productive lives. And often, unfortunately, there is stigmatizing language that is used as we deliver healthcare. And all of these things can help our patients feel devalued, dismissed, and dehumanized. And this adds to the stigma. On the next slide, I would like to now have us think a little bit more deeply about how our own attitudes and behaviors further contribute to this as individual providers. Sometimes we don't have a lot of awareness of our own unconscious biases and hidden beliefs and attitudes about mental illness. And many of those can be deeply rooted in our own family experiences, our own cultural or religious experiences, and we need to be prepared to take some honest looks at that. Ask yourself questions about how was mental illness and mental health discussed in my own family? How is that viewed within my culture? How might that then be impacting the way I approach this with my patients? I think we've made some wonderful advances in the way that we treat mental illness and promote mental health. And sometimes, but at the same time, some providers may still maintain a pessimistic view about, well, if someone is chronically mentally ill, what can I really do to help them? And especially given our culture in healthcare of wanting to find it and fix it, when we're faced with trying to treat mental illness, where it may not be that simple, providers can sometimes become more disengaged. Especially research has shown when trying to help patients who have personality disorders who may exhibit difficult or manipulative behavior, that can start to make us want to avoid or withdraw and communicate somehow that they are less deserving of our care. And then just as humans, if we are not well prepared, have not examined some of these unconscious biases, we may then react to not wanting to care for these patients because of the anxiety and the fear that it brings to us, because all of us want to feel competent and successful. In the next slide, I'd like to now think about what are some of the things we can do to avoid these stigma. One of the things is that we can commit to remaining up to date in what the treatments are. We can understand some of the risk factors that Kim just so eloquently outlined for us from a social standpoint. We can practice a person-first language that will help build trust and work on busting myths that really contribute to some of the stigma and less than optimal care. And the next slide, I'd like us to think about at a practice level in terms of where we are providing care. What are some things that we can do? We can really leverage the power that we have as clinicians to support mental and behavioral health models that are in collaboration with primary care, for example. We can make an extra effort to collaborate with mental health professionals so we're really providing integrated care. That can be something as simple as doing a warm handoff between the healthcare provider and that's attending to physical health needs and those that are attending to the mental or social needs. And then once our patients are engaged in those services, to really be collaborative in the follow-up treatment and care. In the next slide, I want to challenge us to look at some of the community level interventions that we can engage in. Be knowledgeable about some of the resources in the neighborhood and in the community where you are practicing that can support patients, including mental health professionals that are there, including organizations and social service agencies that might support patients in their mental and physical wellness, and then also being open to opportunities to collaborate. For example, showing up as a speaker at an organization that's providing services for people with mental illness and looking for other ways that you can partner with them proactively. Looking at the structural level of things that contribute to stigma and mental illness, on the next slide, I just want to remind us of the importance of leveraging our power as healthcare professionals to advocate for changes in GME funding and training that can support dismantling the stigma. Also advocating for improved payment models for behavioral health services across all payer types, and really committing ourselves to eliminate inequities for those who are marginalized, especially our younger population, also our older adults, those who identify as part of the LGBTQ community, those who are immigrants and may have English as a second language, those who have been incarcerated. Many other groups that we know tend to suffer disproportionately from healthcare disparities. And just as an advocate, to keep an eye out for ways that we can support policies that improve access to mental health. And so in my final slide, I really would just like to remind us that when we talk about dismantling stigma in mental health, it's a call to action about justice in healthcare. Because of all the forms of inequality, injustice in healthcare is the most shocking and inhumane, as Dr. Martin Luther King has reminded us. And committing to dismantling stigma in mental health is a wonderful way for us to be advocates for justice in healthcare.
Thank you, Denise. That was amazing. I am particularly interested in the perspective of self-stigma, and that's a dimension of stigma that I hadn't even thought about. So I'm not going to ask you any questions right now, but I have a couple if we have time at the end. So thank you, Denise. All right, at this point, we're going to turn over to David as our last speaker. David, you are on.
Well, thank you so much, and I really want to thank both Dr. White Perkins and Kim for setting the stage for the discussion today. And I think self-stigma is also something that is critically important to consider, and something that I'll be touching on briefly as well today. So for those of you who don't know me, I would love to first introduce myself a little bit and tell you more about my role and the context in which our conversation is going to happen today. As Dr. Mumin mentioned, I'm the director of our Trauma and Acute Care Surgical Psychology Services, and I have a relatively special role here in that my goal is to meet with folks immediately following the experience of a life-altering event, knowing that we have a huge ability to potentially prevent that event from leading to the development of future mental health concerns down the road. While my practice is specifically focused on trauma, I think that we sometimes forget as healthcare providers that most people are coming to our clinics or to the hospital to get care from us because they're experiencing really significant changes in their physical health. And oftentimes that can lead to changes in their emotional well-being. And if those changes aren't present beforehand, they may develop as they move through that course of care with us. So today we're going to focus a little bit on that self-stigma, the difficulty that an individual may experience as they are starting to move through the process of receiving healthcare, and then what we can do as providers and individuals working in a healthcare setting to not only support our patients, but support our teams in providing that compassionate care. So to understand the process of really developing a mental health concern, I think it's critical to start with the basics. One of the things that we really need to think about is the concept of psychological adjustment and what that process looks like in different individuals as they move through the healthcare pipeline. So psychological adjustment is really the behavioral process of balancing conflicting needs or needs against obstacles in our environment. So in essence, what happens is when we are faced with the stimuli, we experience a need or motive. Uh, if we were sitting in an audience and everyone was out in the auditorium in front of me, one of the examples I typically give is, this is lunchtime, right? Say you forgot to bring your sandwich with you or your lunch with you to the lecture, and you're starting to feel the grumbling of hunger in your stomach. But you're also really interested in what we're talking about, and the learning is just so engaging. So you've got this crisis forming where we've got two different needs that need to be met. One, the need to eat and satisfy our hunger. The second, the need to really satisfy our desire to learn. So in that scenario, maybe we're lucky and we have a granola bar in our pocket, but sometimes we're faced with a situation where we aren't really able to solve that problem as easily. So if we aren't able to attempts to resolve the conflict through what we would call exploratory problem-solving behaviors. And exploratory problem-solving behaviors could look like, well, maybe the lecture's kind of boring, so I'm going to stand up and walk on out and go to the cafeteria and grab some food. On the flip side, maybe it's I'm not super hungry right now and this lecture is really, really exciting, so I'll sit with my hunger and I'll just deal with it afterwards. But a lot of times we're seeing our patients in situations where they don't have the ability to really move through that normal problem solving. For instance, patients on my service may come in with an injury that limits their ability to mobilize. Maybe they shared that before, when I was faced with the stressor, I'd just leave my house and go for a walk. But now because of their accident, they're not able to do that because their legs might not work. We also see that individuals in healthcare settings, although they may come in for an acute problem, may be dealing with more chronic issues that build up over time. And when individuals attempt to move through that process of exploratory problem solving and those needs really don't get met, you can see the development of psychological distress. Now, psychological distress is something that is relatively normal and common. What we're thinking about is when does that distress kind of move into the realm of mental health concerns? And this is where that self-stigma that Dr. White Perkins talked about really comes into play. Because as providers, there's a critical moment that we have when we can support our patients through experiencing a normal emotional response to a really stressful situation. But if we don't feel comfortable having conversations about mental well-being, we may send that message to the individual that we're treating that what you're feeling isn't normal and I'm not comfortable with it, which is then when you can set the stage, instead of it being a healing encounter, to one that further stigmatizes the individual for feeling bad for having an emotional response. So for instance, when individuals come into the hospital and they have a really life-threatening or life-altering scenario that I see folks in the context of, they might share to me, well, I'm just trying to be strong. Or I don't want to cry. My parents are telling me not to cry. And that's a critical point where we can intervene to say, well, I think sometimes crying is a show of strength because you're really being honest with yourself. And if you weren't able to show those emotions, then I'd be really concerned because it's really normal to have emotional changes when this really unexpected life-altering event occurs. So I want to challenge us all to really think about emotions as our ally. We, in the age of living better through chemistry and the advent of antidepressants and psychopharmacologic interventions for mental health concerns, unfortunately have stigmatized normal emotional experiences. And that the goal isn't to eliminate all bad feelings, but to appreciate those feelings for what they are. And if they start to develop into something that Dr. White Perkins had kind of indicated in her conversation as impacting our functioning, that's when we might need to intervene. So before we talk about what's a normal response and what isn't a normal response, I think it's important to also consider the nature of trauma. When we're thinking about healthcare, trauma patients aren't the only individuals who experience these negative adverse life events. And I want to encourage everyone to engage all of their patients through what we would call a trauma-informed lens, realizing that when individuals present to our clinics, whether or not they are coming in for a problem that's directly related to a very serious injury, there's a high likelihood that individuals have had some sort of traumatic response in their past. We know that pre-pandemic, approximately 50% of women and 60% of men would be exposed to a traumatic event in their lifetime. And I have no doubt that those numbers are much, much higher in a post-2020 world. And we oftentimes think of trauma just in terms of the context of the external size of the event. So, an individual has an injury, that's traumatic. But ultimately, the individual's response to that experience is what would lead us to consider whether or not it's traumatic from a psychological perspective. So, for something to happen to an individual, and the individual response to be intensely negative, that would then lead us to be able to kind of classify that as a traumatic experience. But we never want to make any assumptions. And I think that that's part of the goal of trauma-informed care and trauma-informed approaches, is that we oftentimes bring our own bias into that equation. We hear a patient describe a story to us and we immediately think, well, that must have been incredibly traumatic, when it may not have been. So the best thing that we can do is really approach each individual from the perspective of how did this impact you, and how is it something that's leading you to change the way that you're living your life? And if it's impacting you in a negative way, what can I do to support you through that process? So traumatic from a psychological perspective requires that external catastrophic event and the intense negative experience that comes with it. And in terms of our normal acute stress reactions, oftentimes when I'm working with trainees, the first question that I ask is, how do you know if an emotional response is something that's normal or not? And one of the big things, for those of you who are familiar with the DSM criteria for mental health concerns, it normally jumps to the time. Well, if it lasts for a really long time, then it must be pathology. When in fact, it's actually relatively normal to have a range in severity that can last from a couple of days, even to weeks or longer. And the important thing to realize is that those changes are considered to be incredibly normal at this early post-traumatic stage. I want you to also think about the development of health concerns that are acute, or maybe even the lack of change in chronic health concerns, as potentially serving as something that can lead to an acute stress reaction. Say an individual has been receiving treatment from you for several weeks or even months for a specific problem, and they're not really seeing a lot of movement. Their body's not responding the way that you're expecting. You're not seeing a resolution of the symptoms of distress. That lack of change can be an acute stressor for them. So I want us to consider as well that not only can we have emotional responses to the development of new or serious problems, we can also have emotional responses to a lack of change in terms of what we were expecting or hoping to see moving forward. Sometimes it can be something that the patient's expectation for getting better is different than our expectation. And when we send the message of we don't see anything wrong, but they're still not feeling like what they were hoping they would feel like, that can also bolster that internal stigma, shame and guilt of, why do I feel bad if my doctor's telling me that everything's okay, but I still don't feel good? And the important thing at this stage is really to identify that it's very normal to have changes in the emotional response that we have after these really unexpected events. So when we think about that, many people will go on to complete the process and not develop clinically significant distress. And the key to differentiating whether or not an emotional response is something that would be considered normal versus something that might be more in the range of a problem requiring assistance from a professional is that it doesn't really cause functional impairment. So as Dr. White Perkins had mentioned before, one of the most easy ways to really assess this is just say, how has this change in emotions impacted your life? What differences have you noticed now compared to before you had that change in emotions? If they aren't able to really elucidate that, you can start to ask questions about, have you ever noticed that it's really impacting your ability to do the things that you normally would do before? Is it harder to get out of bed and brush your teeth or make breakfast? Is it hard to go to work? Are you finding that you're calling out or canceling social interactions just because you don't have the energy to get up and do it? So functional impairment isn't something that has to be incredibly life-altering and impairing, but something that can also be, more subtle. And by asking the individual open-endedly first and giving them the opportunity to describe how that change has impacted them, about the impact that we have on our patients, but also the impact that we can potentially have on the medical community as a whole, our healthcare delivery systems, and our communities in general. So what we can do is approach each interaction from a place of inquisitive, compassionate care, adopting that trauma-informed lens to understand that a majority of individuals that we work with will probably have been exposed to some form of traumatic experience in their lifetime. We can serve as a role model for our peers, utilizing Socratic method to really explain our perspective of our patients' difficulties. Maybe that frustration or that anger that they expressed, as we talked earlier in the male patient, may be a way for them to mask the sadness they're actually feeling because it's not socially acceptable for men to express what they're feeling in terms of negative emotions. We can role model for our trainees. Instead of saying this patient's difficult, pondering aloud what challenging life experiences they might have had to deal with just to get here to our appointment. And really role modeling for our patients. We want to normalize this experience. Let them know that they're normal people for having emotions. Allow them to express what they're feeling and then inform them that what they're going through isn't something that means there's something that's wrong with them, but that they're a normal person that's having a normal human experience. And if that experience is starting to impact their life in a negative way, that there's special doctors and providers out there in the community that can help them to navigate those problems. We want to ask open-ended questions instead of avoiding or assuming or asking leading questions. I think one of the things that we do, as Dr. White Perkins had mentioned, is ask a question that sometimes leads us down a path because we're afraid of what the answer might be. What will we do if the patient shares with us they're having thoughts about death or dying? How will I respond to that? Because this appointment time is really, really short and I've got 10 other people to see. So we may ask a question instead of saying, have you had any thoughts about death and dying? You're not thinking about death and dying, are you? Which sets that stage for the patient to say, you know what, this person really doesn't feel like they want to talk to me about these things. I think I should probably just say no. Finally, we can use those observe and describe techniques. So I noticed that when we started to talk about, your chronic health concerns, that you started to pull back from me. You got a little closed off and you were looking down at the floor a lot. What are you feeling? Are you noticing some changes in your emotions? So 90% of our communication is nonverbal. And if we notice that when we change topic or bring up a specific area of conversation, that it might lead the individual to change how they're responding, we should approach that from an observe and describe perspective, not making an assumption about what they're feeling, but giving them the opportunity to talk about it. And finally, validation, that we're all human beings and that it takes an incredible amount of strength to have these conversations. So validating not only our patients, but their family members, the support individuals that are there and present for the appointments, as well as our peers and trainees when we really see them engaging patients and our community members in a way that promotes just being a person and supporting them through these difficult experiences. I want to thank you so much for taking the time to talk a little bit about these experiences, and I look forward to answering questions with my colleagues right now.
Thank you, David. That was super informative, and I actually have a couple of questions for you as well, but I'd like to let the audience go ahead and ask their questions in the chat, and we can provide those to our speakers. I'd also like to say that we've been blessed over the course of all of our Henry Ford Physician Network webinars to have an amazing group of speakers, and this session is no exception. All three of you have been incredible in helping us understand the challenges of stigma in mental health. So thank you. So let's see, I'm waiting for questions to come in. I have a question. I got a bunch of questions. Let me start with David. So in the course of your work on the trauma service, you're dealing with patients who are quickly going into a recovery phase. And you talked about how to kind of help them cope with the trauma that they've experienced, especially the mental, psychological trauma that they're dealing with. I'm wondering if or how you detect when psychological challenges are interfering with their recovery. In other words, sort of like the mind-body connection, like are there nonverbal cues, or how do you tell when a patient is not progressing, not because the physical tissue is not healing, but because they are kind of stuck psychologically?
Yeah, that's a great question. And it's also one that I think challenges a lot of providers in an acute care setting because most of the diagnostic criteria we use are geared towards outpatient experiences. So for instance, that functional impairment that we discussed is oftentimes conceptualized through the lens of, does it impact your work, your social, or your other functioning in your everyday life? And that can be hard to assess in a setting where patients are receiving acute care healthcare. So what I typically look for is if there's been a change in terms of the patient's participation with care in the hospital. Maybe they're refusing physical therapy, or they're not really engaging with our therapy teams as much as they were prior to their emotional concerns developing. One of the things that is also critical to assess for is the presence of avoidance-based behaviors. Avoidance behaviors, especially in the context of acute care health concerns or even long-term health concerns, really can set up the stage for complicated chronic problems in the future, like infections, return to ER for pain management. So avoidance can look like anything from, hey, I need more Dilaudid, but they're not really experiencing discomfort. It's so that they can sleep and not have to be awake to deal with the problems. The other things that I see too in terms of avoidance behaviors, back to that brief example of, I just need to be strong, right? So the statement of, I just need to be strong, is a socially acceptable way to say, I don't really want to talk about this. And that in and of itself can indicate that the topic of conversation, whether it be the new functional impairment or the event itself, is too overwhelming to deal with it. So I just can't really go there. And instead, I'm going to put up this wall and not really allow myself to feel what I'm truly feeling. So as healthcare providers, I think that using those observe and describe techniques can be really helpful in those scenarios. So if we notice that somebody has started to disengage from care, and this could even be used in an outpatient setting as well, where, hey, I noticed your levels are different now, which indicates you may not be taking those medications at home like we had discussed before. Tell me a little bit more about that. What's happening? Sometimes taking the medicine makes it more real for people, and it forces them to confront the fact that I really do have a problem. And in those scenarios, especially if they're not externalizing a lot of the typical negative emotions we would associate with mental health concerns, like crying or anger or profound panic attacks, it can be much more subtle. So allowing them to describe what they're experiencing, and then really keeping in the back of your mind, this may be a way that they're avoiding dealing with this problem, helps me to understand if it's transitioning from my normal emotional response to something that's a bit more pathological.
Thank you. That's super helpful. I have a quick follow-up, and then we have a couple of questions in the chat. So I would imagine at some point, David, you encounter a patient who is resistant to all of those tactics that you just described. And it's clear to you that your ability to influence them is going to be insignificant. What do you do then? Like, yeah.
Thank them for being honest. I think my role isn't to force people to talk to me. I'm certainly not self-important. I know that the work that we do is really incredible, and it needs to be done on a timeline that is comfortable to the person that we're working with. So the way I kind of describe it, if they're in a place where they really feel like they don't want to engage with me, is to say, I'm actually really proud that you were able to be honest with me, and I want to thank you for sharing that. And just to let you know, I'm like that dog you feed once, so I'm just going to keep coming back to your doorstep. And whenever you're ready, if it gets to a point that you're ready, I'm here for you. We also do have the wonderful opportunity to have a bidirectional relationship with our patients when they leave the hospital. We recently have established a new part of my program where we have 2 dedicated social workers who contact our patients between 1 and 2 weeks, and then 3 and 4 weeks after discharge, just to check in. So if folks aren't ready in the hospital, we let them know that they can always call our clinic and let us know when they are ready, and we can help them to get into an outpatient and appointment. Or we'll say we'll check in and see how things are going in 2 weeks, and then another 2 weeks after that. So I think giving control is critical. We can't force anyone to do anything. And if we tried to, we probably would stigmatize engaging with mental health providers even more. So the goal really is to destigmatize the interaction with mental health care, and to show them that we genuinely just want to provide assistance, and we'll be there when they're ready.
Thank you. That's great. All right, the first question out of the chat, and I think this one is probably best directed at Denise. And the question is, how often do patients acknowledge that they are in mental health distress, but that they have a specific stigma about using medications?
Yeah, I think that's a great question, because that's a very common challenge. And I think it comes from multiple points, and we need to understand, exactly what is the patient's concern. Is it the stigma that goes along with being on this medication? We have the commercials now that advertise broadly the different medications and the names. Are they worried someone's going to know they're on this and then make conclusions about them? Is the patient fearful of the side effects? Or are they fearful of being dependent upon the medication in order to be normal? Sometimes they feel like us offering them medication means that we don't believe they're strong enough or able to deal with this. So diving into what it would mean for them to be on medication is important to ask. And as was said earlier, I think not sacrificing our desire to have them on medication, not sacrificing the relationship in pushing for the desire for them to being on medication, being person-centered, acknowledging their agency, their power to choose, and saying, okay, I understand, I'll respect that. Let's discuss that later on is really important.
Thank you. That's great. We have another question. I think this one goes to Kim. So Kim, you described your personal story with what happened to your sister, which was helpful and inspirational. But it kind of raises the point that clinicians are sort of obligated, not sort of, they are obligated to report potential abuse conditions. I'm wondering how do we help providers kind of deal with that in terms of not we don't want to stigmatize and force patients into going through a CPS inquiry and all of the drudgery that's involved there, but yet we have to keep people safe. How do we balance that?
Yeah, thank you so much for asking that, because I did have that conversation with my sister as well to help her understand that if any healthcare professional hears information that might be concerning in any way, we do have that obligation to report that. And for me, I think it is about how are we responding to that individual in that moment. Even if we have a concern, that concern shouldn't remove our ability or prohibit our ability to remain empathetic and compassionate with the individual whom we're talking to. And, help them understand that this is a concern and this is why this is a concern to me. And really have that honest and open conversation. I truly think even with my sister's sensitivity to, experiencing CPS in multiple points of her life, if the provider would have approached her with that way, I think she would have had a much easier time understanding the circumstance.
Thank you. That's great. Well, I think we have time for one more question, and this is also a question for Kim, I think, although I think Denise and David may also want to weigh in on it. But the question is, can you speak to the use of V and Z codes in our practices so that we can truly advocate for better identification of SDOH issues and challenges and be able to get financial support for all of this work that we're doing? And I know, Kim, I mean, that's your challenge, is how do you get funding or find places that have funding and connect the dots? But what are your thoughts on V and Z codes? And anybody else can weigh in after Kim if they want to.
So the good news is that anytime we use the SDOH screener in Epic and a need is identified within that screener, Z codes are automatically dropping into the record, and we are sending those Z codes through our claims to our payers. And we do, in fact, receive incentive payments from a handful of payers. But we do, moving towards a more value-based, care-centric world, we do have the opportunity to further cohort and aggregate that information in a more cohesive, meaningful way to bring that information to the payers to say, this is the need of our collective community. This is what we're currently doing to actively support. How can you help us have the funding we need to be more successful in this opportunity?
A quick thought to add to that as well. One of the things that I think it also does is make these challenges more real. When we acknowledge that these are things that are worthy of documentation and include them in our formulation and planning moving forward, I think it sends the message to any other provider that we're collaborating with that these are problems that really do need to get addressed. So billing and coding aside, I think it also serves a critical role in highlighting and illuminating the fact that these concerns are there and that we're trying to do our best to destigmatize them and put them in the framework of how we can help this patient move forward, not just in terms of their specific medical problem, but the challenges that might face overall living a life that's full of health and well-being.
And we know that these social determinants of health impact the physical outcomes that we're all collectively trying to achieve as well. And so I think it's important to be able to have those distinct conversations with our collaborators to help them understand the complexity.
Yeah, and I agree with these comments. I feel like documenting it validates it and also positions us well to really truly practice team-based care in the way we respond to these concerns.
Thank you. I guess we are out of time. I first want to thank our three amazing speakers for sharing their wisdom and their expertise and their inspiration. Also like to thank all the participants for joining in this wonderful conversation. And I hope that all of us and all of you have a new way to think about the challenges that our patients are facing with mental health. And with that, I wish you all a wonderful Memorial Day weekend. Take care, everybody.